Thank you. It's a pleasure to be here, and I'm talking about something. I think Darius's presentation was the perfect intro to what I'm going to talk about, and I think Bob is going to talk about as well, about engaging particularly families, but I'm going to actually talk about wider stakeholders as well. One thing that Jon left off of my bio there is that I'm also a mother, and I am a daughter, and I'm also sometimes a patient. So this is a topic that I feel really passionate about because any single one of us could be on the other side of the table at any given time, taking care of a loved one in the hospital or ourselves receiving care. So I just want you to think about that as you think about what I'm going to share today about how would you want to be engaged if you were on the other side of the table, and how would you want to participate in your own care. So with that in mind, actually, I'm also going to just say thank you to somebody who's not here today, but who is an active collaborator with my consulting work, Erin Moore, who helped me develop this presentation. She's a family leadership coach, and she has provided a lot of really valuable insights and always is coaching me to think about the family perspective and how we receive care. So I'm going to open with thinking about an ancient parable about an elephant. And many of you may have heard this. Raise your hand if you've heard this parable about the elephant before. Good. So this is one that's familiar to you. So if you're thinking about blind men in the desert who come across this elephant, and each one is feeling a part of the elephant to try to describe what it is. And one is feeling the hoof, one is on the tail, one is on the trunk. And the men come into an argument because they're each describing to each other what it is that they feel, what is their absolute truth. So the man at the tail may say that it's a rope, and the man at the trunk may say it's a snake, and the man holding the tusk may say it's a spear. And they come into an argument because they're each describing what to them is absolute truth. And instead of engaging in a conversation to try to find the absolute whole, they're arguing about what they see. And I think we can think about our work sometimes in that way, in that if we are just looking at one piece of the system, the piece that comes naturally to us, the piece that we see, are we predefining what we're looking at instead of looking at the absolute whole picture? So an example here that might be relevant to research, and I think this follows really nicely what Darius was mentioning before, is if we're already pre-selecting the topics that we're researching and pre-selecting the questions that we're asking, or even the types of information that are relevant to get implemented, are we not seeing the picture from the whole perspective? And often I think the perspective that gets left off of the table is that of the patient and family, who actually have the lived experience of living with the condition that we're trying to improve. So by bringing in people who have lived experience, we have an opportunity. The content area and professional expertise, of course, brings a wealth of knowledge of research methods, of content expertise, of guidelines, of implementation expertise. But the client and family also has expertise of what they live with every day, their lived expertise. So by bringing those two perspectives together, we even have a more powerful theory of change. So my challenge to you is to kind of think about, often we think about our work and our research, or in my case, I work a lot in continuous quality improvement. And I hear teams say, I keep forgetting that I need to talk more. Can you hear me in the back? I often hear teams say, well, I want to improve services for families, or I want to do research to improve things for families. And what I'm going to suggest is a slight shift in language and think about improvement with families. And that's it sounds like a nuance, but it's actually really important to think about who's in the room when all of these decisions are being made. And I would maybe even challenge us today to think about, are there any families in the room that are helping us think about what we're looking at and how we're studying? So I'm going to share two examples, and I think this quote really illustrates these examples really nicely. There's no power for change greater than a community discovering what it cares about. And the two examples I'm going to share are about enduring networks that were designed really to create a shared platform where researchers, clinicians, practitioners, and patients and families could come together to make priorities and implement research and findings. So I'm going to draw you back yesterday to Mary Catherine's presentation. Mary Catherine and I've had the pleasure of working with Mary Catherine over the last almost 10 years in applying what she described yesterday as the Breakthrough Series Collaborative Model. So you may remember this model, and she shared the work that we've done together in Chile and also on HV Coin, and there are many wonderful collaborators here from HV Coin. It's great to be in a room of familiar faces. So the learning network model is really similar to the Breakthrough Series Collaborative, but there are a couple of really distinct differences to it. One is it's enduring. So a Breakthrough Series Collaborative really is 18 to 24 months. So those of you that maybe participated in HV Coin came together to work on a common aim, a shared aim, you shared data, and you tested different ideas to figure out how to accomplish that aim. The difference for a network is that you don't necessarily come apart after 18 months, that you stay together. Some networks have been together 10, 20 years, and you're working towards transformational outcome goals. And you're bringing researchers and clinicians, practitioners, patients, and families together. You're really creating a community and a shared platform where that can happen. And one of the things I think is really important, especially important for the group that's here today, is it's an opportunity to integrate both research and quality improvement together. And sometimes I think research and improvement are almost sometimes viewed as at odds of each other, but actually they're quite synergistic and complementary. Continuous quality improvement by nature really is implementing best practice that is generated through research. So it's really the implementation arm of research. And likewise, by doing quality improvement, you engage people in being interested in their data and learning from their data and wanting to inquire more and finding those holes where we don't have the information that we need through quality improvement to then loop back to research. So the two are really nice, and they belong together. They really don't belong in separate systems. So a learning network is an opportunity to integrate these two things together and having a community where everybody's voice matters and is able to prioritize and design that research together. So the first example I'm going to share is actually, it's a little bit of a difficult example for me because it is a really important work, and it actually was meant to be an enduring network. It was meant to be an enduring research network. And the funding was lost actually after a year. So this is a hard example for me to share because this was near and dear to my heart, and the patients and families were so enthusiastic that were part of this network, and the clinicians and researchers too. So it was really heartbreaking when the funding was lost after a year. And I think Darius's point that he ended with about how the role that funders play is a really important one. So the first venture of this network, this was part of PCORI. This was the PEDSnet. This is the Pediatric Learning Health System that brought together these 8 institutions together. And I also want to acknowledge this was done in partnership with Cincinnati Children's Hospital, who was leading the network, and Children's Hospital of Philadelphia. And the first task of the network was to design a study and kind of run a test run of how this would work. And the idea was to build an efficient research system across these 8 institutions with a shared IRB, seamless data sharing across the 8 institutions, and systems to extract the data as well. And so this first survey was really designed as a test run of the system to see how this would go and to consent patients and families for future research. So what we did, we actually came here in Chicago, and we sat clinicians and researchers and patients and families together in a room, and we prioritized research. And patients and families, really, their number one focus was how do we make and maintain long-term healthy choices? And tie these to what really matters to me. I want you to know me and why I would want to lose weight. And then other things like nutritional support, come to my house, see the context that I live in, provide influence and information to make health choices more affordable and accessible, and so on, and bring the care closer to us. And then clinicians and researchers also made their wish list of what they wanted to learn. And number one on the list, understand the family system and the impact of interventions on the whole system. Identify subgroups and phenotypes of patients, and standardizing and spreading best practice. So you can see here that there were synergies across the two lists, and there are also a lot of differences. But if we had just had clinicians and researchers in the room, we would have ended up with a really different list if the patients and families weren't there. And that's really important because they felt empowered by helping to design and to prioritize what together we would study. So we actually ended up studying something that was more around family structure. It was actually kind of the marriage of the two lists, around what does obesity care look like for different types of families. So if you're a family where you maybe have different households where mom and dad live together separately and your child goes off to grandma and grandpa in the afternoon, that's really complex because that's behavior change across a lot of different households, as opposed to a household where it's really just one household. So that was kind of the focus of the initial study. And I just love this quote that's here in orange at the bottom that the patients and families said at that meeting. They said, "You're tracking every possible number about us. We want you to know who we are. We want you to know the warm and fuzzy stuff too. We want you to know our personal goals." So the patients and families really became protagonists in this adventure. So they helped in many different ways. They helped to simplify the survey into 5th grade reading content, reading level. They reduced the content. They said, you know what, a lot of the stuff that's on here, you can get about us in different ways. You already asked us these questions a million times. Let's make this shorter. They helped the clinicians and research. You can see here the flow map. They helped them to design the process for how it would work at each clinic. And they created the videos and the flyers to create the peer-to-peer interest in participating. And guess what? The consent levels were very high for this study because you had patients and families involved from the very beginning, really convincing their peers to participate. But that wasn't all. That was a big piece that they contributed, but that wasn't all. They also helped to design a different model of care, and this is what we would have done if we had continued. So they really helped to think about the key ingredients, what we call sometimes the key drivers. What are the theory of change that would help not only lead to an improved metabolic and physiological parameters, but also well-functioning quality of life, mental health, other things that were really important to the patients and families themselves. And I thought it was interesting, actually, just given that we're talking about precision home visiting here today, one of the things that together the whole community prioritized and started to work on were targeted interventions. So finding different subgroups of patients and families and phenotypes and figuring out what are the targeted interventions and to help customize care, and having patients and families involved in that conversation throughout to figure out who those families were was a very powerful experience for the clinicians and researchers to see how much they had to contribute. So the second example is not as bittersweet. I'm going to share an example from an enduring network that also a collaboration with Cincinnati Children's Hospital, the Cystic Fibrosis Foundation, and Dartmouth that I was part of, and it's really a rare pleasure when you get to be a part of a rich design process and then see through the execution of a network. And we're now in our 3rd year as a network. We'd had an 18-month design process, and we're now in our 3rd year. And actually this afternoon, I'm flying off to our community conference in Minneapolis. And we have a very vibrant patient and family community, which is not to say that it has been easy. This stuff looks like it's easy, but this is really hard. There are inherent power differentials at the table, and you can have patients and families in the room, but to really get true participation and really get people speaking up and feel like they have equal voice is not an easy thing to do. You have to create the right conditions in the right community to make that happen. So in this network, we were actually starting with a very robust community. The Cystic Fibrosis Foundation, since the 1980s or even before, has been doing continuous quality improvement. They've been real leaders in this field. Their clinical research is outstanding. They have more than doubled life expectancy for people living with CF. So when we came together for this design work, I have to say I felt intimidated. I'm like, what on earth are we going to contribute to this amazing community? And the patients and families that came to the table, even the Cystic Fibrosis Foundation slogan is adding tomorrows. And the patients and families that came to the table said, yes, we care about longevity. We want to live longer. And treatment is really difficult. We want quality of life. We don't just want longevity. We want home treatment. We don't want to have to go to the hospital because we're afraid of infections. So really hearing that voice changed the tone of what we worked on together. So you can see here, this was the design process. We started really using a user-centered IDEO design principles. We had a CF one-day shadowing experience where patients and families shadowed clinicians and clinicians shadowed patients and families to really build empathy. What is it like to live with CF? Well, everything here in yellow this is an hourly snapshot of a person living with CF, and everything in yellow is the amount of time they spend in treatment. That's, quality of life. 15 pills before eating. So taking a placebo of 15 pills a day, what does that feel like? Or the fear of having to go into clinic and be afraid that your son is going to catch an infection. And this is actually Erin Moore, who I was recognizing earlier as well, who generously allowed me to share her example here. So this was a really powerful experience just to learn from each other and walk in each other's shoes for a day. And we did multiple things like that throughout 18 months to really build our community. And you can see here, this is our key driver diagram where we really created a shared model of CF care that we're now in our third year of implementing and rolling out. So thinking about this, I kind of wanted to continue on the thought of what matters to different people. And if you find what matters to your community, that is how you will mobilize your community. So some of us think, we're used to structures where we have a very top-down approach, where we're designing the methods, we're designing what we're studying, and then we're rolling it out. And a little shift in thinking is thinking about, this is sometimes called the snowflake model, where you can build organic leadership, distributed leadership, where people will work on what they care about and they will mobilize people to work with them. And patients and families can do that too. So how can you engage patients and families, clinicians and researchers to do what they care about and to convince others to work on it with them? So I'll just share briefly some examples here. As I mentioned, we're in our third year of the Learning Network being rolled out. And here are some different examples of what family leadership, and of course clinicians and researchers also have leadership, but I'm sharing from the family perspective. So at their own care, improving their own care, collaboratively planning for clinic visits. So many of the hospitals that are participating already had robust pre-visit planning processes where they would look at labs and medicines and all sorts of things that need to be done. But nobody was asking the patients and families, who are key ingredients to the visit, what their priorities were for the visit. And that's not an easy thing to do. Our teams have been calling in advance, collaboratively planning for the visits, and even tailoring the visits to meet the needs of patients and families. And it's also been better for our clinicians and researchers because you're avoiding last-minute changes. Well, actually, what I really want to do today is talk to the dietitian, and then they're rerouting everybody, creating a lot of chaos. So this has really helped everybody come up with a more seamless and shared agenda. They're improving care at their own center. So not everybody wants to take leadership at that level, but some people do. So creating participating in multi-stakeholder quality improvement teams, recruiting and orienting other patients and families for advisory councils, for example, and then leading initiatives like creating a nutrition tip sheet for other families. So we have families at Seattle Children's Hospital that are creating tip sheets for other families with infants with CF and figuring out how to provide more nutritious food for their kids. And then at a leadership level, thinking about how to lead the network, motivate patients and families, and recruit and orient other patients and families. So I'll just conclude here by talking a little bit about HV Coin. And I think HV Coin was extremely effective in mobilizing a lot of different perspectives and stakeholders. But families, there were many quality improvement teams that did engage families, but it was a little more ad hoc. It was to the extent which families wanted to, or teams wanted to engage families. So in the 2.0 version, we are kind of creating a more intentional design to build family leadership. And I'll just end with this quote here, and thinking about that the power of a community or a learning network is to create a structure where people can participate. People intrinsically are motivated and want to contribute and help. So you think about Sign Up Genius. Has anyone ever used Sign Up Genius? Oh, come on, there've got to be a lot of like PTA parents here. Okay, not many parents, not many hands up. Well, I think, if you think about Sign Up Genius as a way to organize a potluck, so not everybody's bringing the same thing. You can think of a network in the same way, that you're creating channels and you're creating structures for people to contribute and help and participate. And that one of those groups of people are patients and families. So I think this quote is really salient here. This is from an HIV network across 5 countries that I helped to design and implement with the University of Washington. And this was one of the patient advisors, and one of the things I thought his insights were really important here, where he was saying, not only do I feel like people listen to what I have to say now, but I also feel like I have more agency over my own care. That somehow being able to lead and participate has also created agency in your own well-being. So I'll just say thank you, and also extend thank yous to the many people in the room here that I've worked with HB Coin, and of course the other learning networks that I've had the opportunity to contribute to. Thank you.